Okay, welcome to this lecture about hypertension. We will cover hypertension through some case studies, and then we will explain more about the medication of hypertension, special population needing special treatment. We will cover most of things about hypertension in this lecture. We will go through the patient case number 1. A patient is being seen for consideration of hypertension therapy. He is currently taking simvastatin 40 mg at bedtime. Which of the following antihypertensive medication have drug-drug interaction with the patient's current simvastatin therapy? We have fosinopril, amlodipine, hydrochlorothiazide, and atenolol. Which one of these will interact with simvastatin? Have 20 seconds to think about the answer. So the answer is amlodipine. So let's go through the rationale for this answer. Here we have a CYP interaction, CYP453A interaction, where amlodipine will inhibit the metabolism of simvastatin, so it will increase its blood level. And we know that the side effect of simvastatin usually the most concerning is myopathy and rhabdomyolysis, so this side effect will increase. So here is amlodipine is not recommended to given along with simvastatin, and if in case we need to give them together, so the maximum dose for amlodipine will be for simvastatin will be 20 milligram per day. This is to avoid the side effect of myopathy and rhabdomyolysis. For the second case, a 60-year-old female present complaining of increased swelling in her ankles. She states that these symptoms started after recent changes to her blood pressure medication regimen. She cannot recall what changes were made. The patient's current therapy consists of losartan, metoprolol, phenidipine, and chlorthalidone. Which of the following medication is most likely to cause this complaint? So is it chlorthalidone, phenidipine, losartan, or metoprolol? Have 20 seconds to think about the answer. Okay, and the answer is phenidipine. You must be aware and confident that is a very common side effect from calcium channel blocker, which one of them is phenidipine, as mentioned here, have a side effect to causing ankle swelling because this medication cause peripheral vasodilation, so it will cause ankle swelling or swelling of peripheral blood vessels. So phenidipine belongs to the dihydropyridine calcium channel blocker, so it causes peripheral edema. Then we will discuss some key facts about hypertension. So what are the blood pressure targets when you are treating a blood pressure or hypertension patient? So what you are looking for a target to achieve? We have three main targets. The target for all patients, it should be less than 140/90 millimeter mercury. We have a higher and a lower target. The higher target achieving less than 150/90. This is applicable for patients who are above 80 years of age, or they are frail, or they are unable to achieve this blood pressure without risk of fall. So we are somewhat lenient with this patient. We will allow them a more higher blood pressure target. The blood pressure target will be lower or more tight for patients who are having chronic kidney disease and diabetes with albuminuria. So in this case, albuminuria mean albumin creatinine ratio above 30 mg per 24 hours. So this patient, we need to have a more tight blood pressure, so their target should be less than 130/80. What about lifestyle modification that we recommend for patient for hypertension? In the initial, after diagnosis of hypertension, we have some lifestyle modification advices we need to give to the patient so that it can improve their blood pressure. The first thing is weight loss, meaning that the patient should maintain a normal body weight, which is based on BMI or body mass index, in a range of 18.5 to almost 25 kg per meter square. The patient need to adopt DASH diet. What mean by DASH diet? DASH diet means that he need consume a food rich in fruits and vegetables, low fat dairy products, with reduced content of saturated fat and total fats. Reduced salt intake is essential and very specific to patients with hypertension. The maximum salt intake totally per day should be less than 3.8 gram per day, or we can say less than 4 gram per day from all sources of sodium. Aerobic physical activity means the patient that should have regular physical activity, meaning at least 4 sessions per week. Each session should last at least 40 minutes per session. It should be involving moderate to vigorous intensity physical activity. Decreasing alcohol intake, also it has high impact on improving blood pressure, and this should be generally less than 14 drinks per week, and if we divide it per men or women, for men less than 2 drinks per day and women less than 1 drink per day. Let's discuss about drug classes that used for treating hypertension patients. The first and very most important one is angiotensin converting enzymes. We can abbreviate it as ACE inhibitors. And from these drugs we have benazepril, captopril, enalapril, fosinopril, lisinopril, mooxapril, perindopril, quinapril, ramipril, trazodone. So we are calling them prils. You need to memorize at least 3 or 4 of this medication. What's the key facts about ACE inhibitors? The main side effect is that they cause hyperkalemia. It's contraindicated in patients with severe bilateral renal artery stenosis because it will cause acute renal failure in this patient. It's avoided in pregnancy and in patients with history of angioedema because angioedema is one of the main side effects of this medication. And the main side effect is dry cough, and in case this happens, the patients need to switch to ARB or angiotensin receptor blockers. So the main side effect is hyperkalemia and dry cough and angioedema. There is a point here about the starting dose should be reduced to 50% in patients who are on thiazide or volume depleted or very elderly because of risk of hypotension. So this medication have a risk of hypotension. So reduced starting dose to 50% is this group of people. Second class is ARB, angiotensin receptor blockers. This type medication will block the angiotensin receptor, and this class involve valsartan, candesartan, losartan, irbesartan, olmesartan, telmisartan, ibrosartan, and azilsartan. So they are called sartans. What's unique about this medication? They are very similar to ACE inhibitors. They can cause hyperkalemia, but they do not cause dry cough. So they are the alternative for ACE inhibitor in case the patient having dry cough. They are contraindicated also in bilateral renal artery stenosis as they cause acute renal failure also. Also, they are contraindicated in pregnancy and angioedema. The same applicable for starting dose to be reduced to 50% in patients using thiazide, volume depleted or elderly because of the risk of hypotension. Third class of this medication will include calcium channel blockers, And in calcium channel blocker, we have subclasses. We have dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. For the dihydropyridine calcium channel blocker, we have amlodipine, phenolidipine, ezradipine, nicardipine, nifedipine, and nizoldipine. What's the key facts about this medication? They are more potent peripheral vasodilator than the non-hydropyridine calcium channel blocker. So they work on peripheral blood vessels. So that they are very effective in hypertension because their effect on the blood vessels. And the main side effect is that as long as they cause vasodilation, they will have a reflex tachycardia. They will cause dizziness, headache, flushing, and this is from the vasodilation. Peripheral edema also due to vasodilation of peripheral blood vessels, which is a very common and very important to know that it may cause ankle swelling, and in this stage maybe the patient need to switch it to another group of medication. They have additional benefit in Raynaud's syndrome because in Raynaud's syndrome there is peripheral vasoconstriction or cold extremities, so that they will cause peripheral vasodilation and will help to improve these patients. Second subclass of the calcium channel blocker, we have non-dihydropyridine calcium channel blockers. Under this group, we have diltiazem and verapamil. So the XR products are preferred in hypertension. This drug main effect on the heart, not on the blood vessels. So it may produce heart block because it decreases the cardiac conduction. So especially with combination with beta blocker, so it may cause heart block. So in this case, it's better avoided with beta blockers. They have additional benefit in patients with atrial tachyarrhythmia. As we mentioned, they depress the conduction. So if the patient having tachyarrhythmia, which is a high heart rate, so there will be a benefit in these patients. So mostly they are reserved for atrial tachyarrhythmia. They are not usually used in hypertension. The third class is diuretics, and diuretics have many subclasses. The first subclass is thiazide diuretics. Under thiazide, we have chlorsalidone, hydrochlorothiazide, indapamide, and metolazone. The key fact about these drugs that hydrochlorothiazide is a thiazide type diuretic, while thiazide-like diuretics are chlorsalidone, indapamide, and metolazone. The dose should be given in the morning because they will cause diuresis, so not to interrupt patient at night, so better to give the dose in the morning. They are more effective antihypertensive than loop diuretics in most patients. Use usual doses to avoid adverse metabolic effects. They have side effect affect the metabolic effects. They cause hyponatremia, hypokalemia, hypercalcemia, a lot of hyperuricemia, a lot of electrolyte abnormalities. So hydrochlorothiazide, chlorsalidone, and indapamide are preferred, and they are the most prescribed in this group. Chlorsalidone is approximately 1.5 times potent as hydrochlorothiazide and longer half-life. They have additional benefit in osteoporosis, so use with caution in patients with history of gout because they can cause hyperuricemia. Second subgroup of diuretics is loop diuretics. They are strong diuretics like bumetanide, Burinex, furosemide Lasix, and torsemide Dimadex. Also the dose in the morning to avoid nocturnal diuresis. If it's twice daily, so the second dose should be late in the afternoon, not before sleep. Higher doses may be needed in patients with severely decreased eGFR or heart failure. They are preferred over thiazide in patients who are having renal dysfunction or resistant hypertension. The third subclass is potassium sparing diuretic Potassium sparing means that they conserve potassium, avoid potassium loss, like amiloride or combination of amiloride with hydrochlorothiazide, which is modiuretic, or trimetrin with hydrochlorothiazide. So they are weak diuretics, but they are usually used in combination with thiazide to minimize hypokalemia, as we know that thiazide are causing hypokalemia. They cause potassium loss. So to avoid this side effect, we are using a potassium sparing diuretic along with thiazides. They do not significantly lower blood pressure unless they are used with thiazide because they have a weak effect. They should be reserved for patients experiencing diuretic-induced hypokalemia. Avoided in patients with CKD if the creatinine clearance less than 30 ml per minute. It may cause hyperkalemia, so because they conserve potassium, especially if they are combined with drugs that cause hyperkalemia, like ACE inhibitor or ARB, as we mentioned before, or direct renin inhibitors or potassium supplement in the same time. The other class with aldosterone antagonist. In this class we have eplerenone, spironolactone, and combination of spironolactone with hydrochlorothiazide. So again, dose in the morning, and if twice daily, the second dose should be late in the afternoon to avoid nocturnal diuresis and interruption of patient's sleep. Spironolactone often used as add-on therapy for resistant hypertension. Usually if patient having resistant hypertension, he is on double or triple therapy. The next stage is to add spironolactone because if the patient resists 3 or triple therapy, in this case he is classified as resistant hypertension. So we need to add spironolactone as this stage. Also avoided with CKD if creatinine clearance less than 30 ml per minute. It causes also hyperkalemia because aldosterone will cause hyperkalemia also, and also especially with medications that cause hyperkalemia like ACE or ARB, direct renin inhibitors, potassium supplements. Now for beta blockers. Beta blockers also have many subclasses. The first class is cardioselective beta blocker. Under this class, atenolol, tenormin, betaxolol, bisoprolol, which is Concor, metoprolol, lobresol, which can have also XR product with toprolol XL. What's the key facts about beta blocker? Abrupt discontinuation or stopping may cause rebound hypertension because prolonged use of hypertension will cause upregulation of the receptors, means there is more receptor for beta, more beta receptors. So if you stop the medication, so epinephrine will cause effect on more receptors, so it will cause hypertension again. So it should be discontinued gradually. The cardioselective means that they are selective. They inhibit beta 1 receptor at low or moderate dose, but higher dose can block the beta 2 receptors. So they are selective in moderate dose, but in higher dose they can lose their selectivity. It may exacerbate asthma when selectivity is lost because the effect on beta blocker, mainly the issue with blocking beta 2 receptors that cause bronchospasm, and should be avoided in asthmatic patients. It has an additional benefit in patients with atrial tachyarrhythmia or preoperative hypertension because the blocking beta 1 receptors will also decrease the cardiac conduction, so it has a benefit in atrial tachyarrhythmia. The second subclass is non-selective. Now, nadolol, propranolol, or propranolol long-acting, or timolol. So again, abrupt discontinuation will cause rebound hypertension. It inhibits beta 1 and beta T receptors at all doses, so they are non-selective at moderate or high doses. So it will exacerbate asthma at any doses, so it should be avoided in patients with asthma or respiratory disease. They have additional benefit in a specific patient with essential tremors, migraine headache, portal hypertension, and thyrotoxicosis. So we can find this indication on beta blocker, but for the non-selective, which is most common with propranolol especially. The other subclass is beta blocker with intrinsic sympathetic activity like acebutolol, cartolol, bindolol, acebutolol. Also, abrupt discontinuation will cause rebound hypertension. It's contraindicated in patients with post-MI. There is no clear advantage of these agents, so they are not commonly used in practice. Another class will have mixed alpha and beta blocker. We having in this class carvedilol, which is dilatrend, and labetalol trandate. Again, abrupt discontinuation will cause rebound hypertension. This is a general side effect for all beta blockers. They have additional alpha blockade, which produce vasodilation and more orthostatic hypotension. So when they block alpha receptors, they will cause orthostatic hypotension as a side effect. The last class is cardioselective and vasodilatory beta blocker. In this group, we have nebivolol. Also, again, abrupt discontinuation will cause rebound hypertension. They have additional vasodilation but do not result in orthostatic hypotension, so they are commonly used as a preferred beta blocker due to this fact that they do not cause orthostatic hypotension. We have other agents so that can be used in special cases like alpha blockers, like doxazocine, Cardura, or brazosine minibres. The first dose should be given at bedtime because alpha blocker, as we discussed before, they cause orthostatic hypotension. So this dose should be given at bedtime to avoid patients fall. Patients should rise from sitting or lying down slowly to minimize orthostatic hypotension. And they have additional benefit in men with benign prostatic hyperplasia because it improves urine flow. So if a patient having both hypertension and PBH, it's recommended to use alpha blocker in this case. Direct renin inhibitors. In this class we have aliskiren. It may cause hyperkalemia in patients with CKD and diabetes, or in those receiving a potassium sparing diuretic or aldosterone antagonist ACE or ARB. They can cause acute kidney failure in patients with severe renal artery stenosis like ACE or ARB. Also, they are avoided in pregnancy. So they are very similar in effect and side effect and contraindication like ACE inhibitors. Central alpha 2 agonists. In this class we have clonidine, catapres, or methyl dopa aldomate, or we have clonidine patches, catapres TTS. Abrupt discontinuation also will cause rebound hypertension. Most effective if used with thiazide to diminish the fluid retention because they have a side effect of fluid retention. So it's better to use thiazide with this type of medication. Clonidine patch is replaced once per week, so it's a benefit for compliance. It can be used only once weekly. Now we will cover the main guideline for treatment of hypertension. So initial drug therapy will depend on compelling indication or no compelling indication. Compelling indication means there is other disease conditions that need to be considered. If no compelling indication means that the patient is having only hypertension and no other diseases. So if the patient have no compelling indication, so we can divide patients into stage 1 hypertension and stage 2. In stage 1, the systolic blood pressure is between 140 to 159 and the diastolic from 90 to 99. In stage 2, it's above 160 over 100. So for stage 1, we can start with monotherapy, and the preferred agent, as we mentioned, is ACE inhibitors, ARP, calcium channel blocker, or thiazide. If patient is not controlled, we can move on to drug combination from these agents, ACE or ARB, calcium channel blocker, or thiazide. For stage 2, when the systolic blood pressure is above 160 and the diastolic above 100, so we start directly with 2 drug combination from ACE or ARB with calcium channel blocker or ACE or ARB with thiazide. And if patient is not achieving the blood pressure goal using the 2 drug combination, so we need to jump to triple therapy from ACE or ARB, calcium channel blocker, and thiazide. After this stage, the patient will be considered as resistant hypertension, so we need to add spironolactone for this type of patients. What about the compelling indication? Compelling indication means the patient will have other disease conditions that need to consider specific therapy to add. So if a patient having heart failure with reduced ejection fraction, so he should be on standard therapy of diuretic like Lasix or furosemide with ACE or ARB and beta blocker. This must be in this his treatment. Then we need to add on aldosterone antagonist for a specific patient or if needed to maintain control. For patient post MI, if having MI or STEMI after MI, he must be on beta blocker. Then we add ACE or ARB. If patient having coronary artery disease, he must be on beta blocker. Then we add ACE or ARB. The add-on will be calcium channel blocker or thiazide. For diabetes, the preferred agent is ACE or ARB. So any patient with diabetes and hypertension, he must be having ACE or ARB in his treatment regimen. The second stage is to add calcium channel blocker, and finally, if not controlled, so we go for thiazide or beta blockers. For chronic kidney disease, also similar to diabetes, patient must be on ACE or ARB because they have a benefit in patient with kidney disease. For recurrent stroke prevention, patient must be on thiazide or thiazide with ACE inhibitors. Now what about comorbid condition? If a patient having special disease condition in asthma, so as we discussed before, we need to avoid non-cardioselective beta blocker because they block beta 2 receptors and exacerbate asthma. For benign prostatic hypertrophy, so it's essential to have alpha 1 blocker, and it should not be used as monotherapy, so it should be used with other medication for hypertension because it improves urine flow and decrease blood pressure in the same time. But the fact that they are the weak diuretics, so it need to combine with other a weak antihypertensive medication, so it need to combine with other medication. For erectile dysfunction, so the patient need to avoid centrally acting agent like clonidine because they further deteriorate the condition of erectile dysfunction. For essential tremor, as we mentioned, beta blocker, the non-cardioselective one like propranolol is preferred. For heart failure, so ACE or ARB beta blocker, and from beta blocker there is a specific 3 type of beta blocker should be there, like bisoprolol, metoprolol, Arcan, and carvedilol. They are proven to be effective in beta block in heart failure, Not all beta blockers are recommended. For hyperthyroidism, we mentioned beta blocker like propranolol will have a benefit because in hyperthyroidism, most patients will suffer from tachycardia, so propranolol will be beneficial to decrease the tachycardia. So we'll go for a special population. For African Americans, the diuretics, unless contraindicated, are more effective and calcium channel blockers. So they usually respond more better to diuretics and calcium channel blockers. For elderly patients, thiazide-like diuretics are preferred. Calcium channel blocker, which are the long-acting, because most of these patients are having some type of arrhythmia, so it will be beneficial to having calcium channel blocker. ACE or ARB. Also need to avoid alpha-1 blockers combined with alpha and beta blocker or centrally acting alpha-2 agonist because of the side effect of postural hypotension and risk of fall. In pregnancy, not all medication are approved in pregnancy, so beta blocker is effective and safe like labetalol. Methyl dopa or aldomate is safe. It's very important to avoid ACE or ARB or direct renin inhibitors because they are teratogenic.